This is about the challenges of interpretation and application of models. Let's start with what the word psychodynamic psychotherapy actually means. People lack clarity about why we call it psychodynamic in the first place. It's just because of Freud. Because when Freud was a first-year medical student, his supervisor was particularly interested in thermodynamics with Ernst Wilhelm Brucker's concept that energy systems are closed systems, and when you have energy going in, something else has to come out. And then put up the idea that if you have something called thermodynamics, perhaps you should have something called psychodynamics. If you have a system that has psychic energy, and if there's too much inside it, then it has to come out in some other way. Freud took that seriously. He actually thought at one stage that it was anatomical, in that there were literally neuronal pathways that were associated with particular psychiatric manifestations. The whole concept of psychodynamic psychotherapy is this idea that human beings operate like energy systems, with the mind having things like psychic energy, repressed impulses, drive theory, and so on. Right from the beginning, we're having a number of concepts that are useful to aid understanding of the patient, but we are challenged when we try to say, what's the evidence for that? What is the science for that? Does the person have something called a psychic energy or a regressive impulse? Then after that, you have attachment theory, which looks at the early forms of childhood attachment and postulates that the relationship between a child and their parents or significant caregivers sets up potential personality dysfunctions or changes later on in life. But then you also have something called the self-object theory, the self-psychology theory, or object relations. These things all look very disparate, and the last count of psychodynamic psychotherapy models I had was approximately 170 different schools of thought. But they all actually do the same thing. They're all there to try to help understand why we are seeing what we do. There are some things that all of them actually agree on. The parallel that I like to use is that you have all these different Christian denominations, but they all have the Nicene Creed. So they all have particular things that everyone agrees on. The strange thing that everyone agrees on is that there is something called the unconscious. And there is also something called defense mechanisms. No matter which school of thought you look at, they'll all differ as to what the defense mechanisms mean. They'll differ about why people are narcissistic. The self-psychologists have a concept of something called healthy narcissism, whereas others would think of narcissism and anything associated with self-preoccupation as being potentially pathological. But it doesn't matter. It's about, does this make sense to the therapist in a way that is going to be able to convey something meaningful towards the patient? So this is really going to depend on your supervisor. It's going to depend on your colleagues. I enjoy any opportunity I get to watch an attachment theorist talk to a self-psychologist, because inevitably there's some sort of argument breaking out within 20 minutes. Rarely blows, but usually arguments. But they're both actually on the same track. They are both trying to come up with something that we can't physically see, but is nonetheless valuable, because despite all the ridiculous number of these interventions, there are patients who do well as a result of them. And these are coming from people who have made incredible changes on a fundamental basis of patients from the models that they're espousing. For the novice, I generally recommend looking at Gabbard. He has the distinction of probably being the only psychotherapist no one disagrees with. Gabbard has a beautiful model-independent, pragmatic approach, which looks at all the stuff that everyone agrees on: unconscious, transference interpretation, countertransference interpretation, personality disorders, defense mechanisms. Everyone else is going to differ about the individual models, and I certainly invite people to follow down the rabbit hole of individual psychotherapeutic models with the right supervisor who is particularly trained in those areas, and make up their own minds about what's going to be helpful. You can have all the research about the evidence for this model or that model and so on, but every single randomized control trial or evidence-based experiment has yielded one form of psychotherapy being superior to the others, and that is eclectic. Anytime you have a psychotherapist who is trained in multiple models, they always win compared to anyone who's the purists. And that's because each model has its place.